Hi, my name is Jessica Nelson, and this is the Mental Health OT podcast. Today, we're going to be interviewing Dr. Halley Read. She has been an OT for 10 years and has clinical, teaching, and research experience in mental health practice, student wellness, and mental health care policy and legislation. Starting her occupational therapy career in community health, she provided services to young, emerging adults and adults with mental health and substance use disorders. She is passionate about integrating occupational therapy, public health, and knowledge translation to change healthcare systems and practices. She's a dedicated member of her state and national association, advocating and using occupation and our therapeutic scope to change systems, support communities, and build. So without further ado, let's get to the episode and start talking with Dr. Read. So I would just like to say hello and welcome to Dr. Read. I'm really grateful that you agreed to be on the show. And I just want to let you know that our interactions this far have been really great. And you've been really consistent in your replies and really helpful in meeting with me and talking with me. And yeah, I'm just really happy that you're here.
Oh, well, thanks for having me. I'm honored to be here.
So I just wanted to start out the show by asking you a pretty basic question. Sometimes it's basic, sometimes it's not. But to just describe OT in your own words for people who are listening who might not understand OT, maybe, or even OTs who are kind of struggling to describe it themselves.
Yeah, definitely. Occupational therapy for me is really about helping people do the things they want to and need to do. And there are many reasons that gets difficult or many reasons that stops. But we really look at people as occupational beings, meaning the things they do to occupy their time. And some of those things are because we have to, and some of those things are because we want to. And as occupational therapists, we get to strategize and problem solve and get creative about how people do those things again or do them for the first time or try new things as a means of finding health and wellness.
Really well put. I might steal a couple of those for my elevator speech.
Go
Still
for it.
refining it. Yeah. So with that, I also want to ask, how would you describe OT's role in mental health? So how does that go along with mental health?
Yeah, absolutely. That's a great question. I'm someone who I think through training and experience has just learned that it's all about that mental health piece. You know, when we go to the doctor or we go to our provider and we are asked what's wrong, we don't say necessarily all the time that it's always about this thing that hurts or this symptom I'm having, but that you can't pick up your grandkids or you can't work the same
Mm-hmm.
way or you can't do these things. And so I think it's in the doing of life that we find that mental health. And so sometimes it's struggling with a change in your life, or sometimes it's living with a really serious mental illness like major depression or schizophrenia, and you need an OT to help you navigate living with that illness and engaging in life to the same degree of satisfaction that you did before, or in a way that is joyful or happy for you. So I think all of life's doing is about finding mental health and feeling good about ourselves. But for some individuals, that's really, really, really challenging. And OT is one of the only professions I think that can help them navigate different environments and live to their fullest capacity.
Like that you kind of brought up the example of like when people go into the doctor, I think, yes, they do kind of like say the symptoms, but at the same time, they relay to their doctor like how it is impacting their lives and then
Mhm.
bringing up those specific occupations. And I think that sometimes it's unclear whenever we think about our role as OTs. Well, like, what exactly are we qualified to do within mental health? And like, if we're working on doing, how does that tie into mental health? Yeah, just like kind of clarifying those roles and establishing like, well, yes, we're working on doing, but it also ties into mental health. And yeah, I think that the way you explained it is really well. But I also think that like once you get into like the nitty gritty of it, it might not be um, as easy to understand, I guess, if that makes sense.
Yeah, absolutely. I think I like to think about kind of why I got into OT. I
Hmm.
had always been interested in being a counselor or a psychiatrist. But when I realized that OTs meet people where they're at and help them do and engage in what's right in front of them, that's when I realized that, I can talk about and teach someone problem solving skills,
Hmm.
but as an OT, I get to help them do that and try it. So I worked with counselors all the time in my career. So maybe in a session they talked through ways to problem solve or how to cope with the stress of problem solving. As the OT, I got to actually walk alongside and help them do the problem solving of figuring out the bus route or getting a prescription filled. You can talk through something, but when you have to actually take the actions or take the steps, that's when it can get really challenging. Maybe you don't have a cell phone that works, or maybe you have to use a payphone, or whatever it may be. But having to do that in vivo, like in real life, is where I think OT for mental health comes in.
So what you kind of said is like, we're not exactly like talk therapy. So
Right.
we obviously work on like the doing and stuff like that. So how important do you think it is to have an interdisciplinary team working together? So like having like, the psychologist or like the psychiatrist or counselor kind of going through that talk therapy and then also partnering it with an OT. And what does that kind of look like to you and what are the benefits to that?
Yeah, I think interdisciplinary teams are not only like a benefit to somebody, but they're just how things go now. And one of the things I've seen in my career is that we're going to all operate on interdisciplinary teams of all different kinds. And the great thing about that is that it means the people we're serving can get their needs met, even if that is not through my services. So, for example, if somebody connects better with their peer support specialist or their counselor, I'm not going to stand in the way of that. I want them to be able to
Mm-hmm.
feel the benefits of that therapeutic relationship. But then that also means that I have a means as a member of that interdisciplinary team of helping that individual problem solve, maybe behind the scenes. So some more of that case management stuff that we think about more traditionally, I can help a counselor problem solve before or after a session, even if I don't directly see the client. So I think that's the real benefit of interdisciplinary work as an OT is you help people share the load of helping serve these individuals that we treat. Because it can be a lot.
Yeah.
So we get to still be OTs even if we're not directly treating a client.
Like informing maybe
Mhm.
like if we are working with a client, but then like also like informing other parts of the team what we see, and then also your example of kind of like even if the client's like more comfortable working um, with another member of the team, like you collaborating maybe before or after a session
Yeah,
to
yeah,
help support.
right,
Yeah.
right. Because each profession has strengths and um, challenges, and what that means is that maybe the OT sees things that another profession doesn't, and vice versa. We think about things that other professions may not, just like they do, and we can point that out to them and say, "Have you thought about maybe what the environment looks like, or the sensory needs that they're having, or their cognition?" And then, maybe the counselor can think about, well, there's a lot of trauma, and this was what they faced as
Mm-hmm.
a child, or those kinds of. You can blend your strengths together so that everyone's challenges, are overcome or all the problems are solved. I think that's the benefit of interdisciplinary work.
So whenever like a patient is going through talk therapy and they're speaking with their counselor about those strategies that you mentioned. So, like um, maybe like anger management or dealing with stress, this and that. Um, and then we see the client and then we kind of put that into effect with like their everyday life. Can you go a little bit deeper, maybe as to what that may look like specifically for interventions?
Yeah, absolutely. So I think sticking with your example of anger management, I think there's one of two ways that it can be approached as an occupational therapist. It can be individually,
Hmm.
with the client, or in a group setting. Those are very common in mental health care systems to have group therapy or group skills training sessions. Um, and it's probably going to depend on what the client's preference is, what your setting allows, and maybe, whether or not they have some level of anger management skills prior to a group setting. It really just depends on the symptomology for the client. Um, but I think in individually or in a group, you could role play
Hmm.
when someone is not angry or not elevated, what they would say, how they would say it, and kind of debrief why it's important to think about what you're saying and how you're saying it. Anger management can be approached through communication skills groups. I've run those in the past. So, what kind of communicator are you? Are you assertive? Are you more passive? Do you tend to move quickly through a conversation, or do you take more time to process? So, exploring those different things through a group can be beneficial too. I've also found that putting people, in the moment in a situation where they have to solve a problem, it helps identify their frustration tolerance. So, waiting in line to order a cup of coffee, do
Hmm.
they get really antsy? Do they walk away from the line? What are they sacrificing because they can't process their own stress or rising anger levels? And then talk through that when they're less irritated about what that means when don't you're not able to buy that cup of coffee, or you choose to walk away from something and not return back to it. That kind of thing.
Devil's advocate for a second. And I am gonna ask, so let's say that a counselor or a psychologist was running a group. Do you feel like role playing is a modality that they would use as well? And if so, like how would us role playing in a group setting kind of be different than a different profession? Or like the use of like those modalities that you were referencing?
Yeah, that's a great question. I think it is a modality we could use. I would refer to it as kind of skills practice or skills training. So you're working on, a performance skill that the client doesn't have yet, in hopes that you're helping them manage a client factor, which would be their stress level. But then we would extend it out and take it to the point of which we apply it to those situations in everyday life. Like, this isn't just a skill you practice in group, but this is reportedly coming up, in your work environment or in your relationships in your own home. So let's take it a step further. And now that you've practiced it well in group, let's see how it goes doing that at work, or, approaching your loved ones at home about what you're working on and practicing that in those occupations, in those roles and routines that you have. Because I know that sometimes we look like other professions, but I
Mm-hmm.
think at the end of the day, what we're trying to accomplish and how we're trying to accomplish it is what makes us different.
I really like emphasizing whenever we're working with clients in like an individual way, like even if we're doing a group, um, I think each client obviously would have different triggers, different instances that they may get more upset in certain situations. So um, instead of it being like a general, here's anger management, we're doing this group, but like taking the time to individualize it and have those discussions with each client and say, well, for you, like you identified these triggers. And so, like, let's break this down and like, this is how this is going to benefit you while engaging in this.
Yeah, absolutely.
Yeah.
Like, we take the piece that maybe is impeding functioning, help tweak it, and then put it back into the picture, right? And versus just generally working on anger management. We can say everyone would benefit from it, but why would that one client benefit most from it? How is it going to help them function? How is it going to help them with their performance? Versus just, this is a group everyone goes to and here's why, but this is why you're in this group because you told me you've blown up at work. Well, let's think about the occupations involved in that and the activities and how anger management can get better for you so that you can go back to, a
Yeah.
job you enjoy or keep a job for a longer period of time, like whatever that goal may be for the client. Um,
Yeah.
it
I think
looks very reduced when we're doing it, but I don't think that that's our end goal. Is not a reductionist outcome. It is very much full picture, full scope. How is that helping the person function?
for me, because like the majority of my job right now is leading groups. And so I think I've kind of struggled with, like, from the outside looking in, it kind of just looks like, oh, I'm just doing, like, I don't know, this exercise group or this journaling group or whatever I'm doing. And I think, like, in my mind, I know what I'm trying to achieve, but like I also struggle with it too, trying to individualize groups. Which you said that kind of like figuring out, what each individual needs. I guess, how would you recommend OTs who lead groups kind of establish or utilize I'm saying a lot.
It's all right.
The evaluation process.
Yeah, yeah.
So, like, what does that look like when you're leading a group? Do you do it like individually, or like, what if you don't have time to do it individually? How do you like tackle that as a group? What are your thoughts on that?
I think initially I would say it's probably very setting dependent. If
Mm-hmm.
you're working in the community as an occupational therapist, you may have an individualized treatment plan that you're operating from or have even contributed some goals to for your client. Whereas if they're inpatient psychiatric unit, the goal's pretty clear across the unit what you're trying to do. You're trying to help people stabilize, manage symptoms, and get back out into the community, right?
Mm-hmm.
In a perfect world.
Mm-hmm.
So sometimes I think groups can feel like you're just doing that activity with them without really tying it back to maybe a functional goal that they have. But there's enough evidence also to say that engaging in things for the sake of that engagement is healthy and can bring stabilization and wellness. But I think in a community health center like the ones I've worked in for people with mental illness, if their goals are around like managing symptoms in a group of people, paying attention, managing cognitive deficits. Those individual goals can be applied in any type of group setting or group therapy of their choice. Does that make sense? So
Mm-hmm.
maybe they're coming to a group that's about cooking, but they're working on socialization. Well,
Mm-hmm.
it's a group cooking exercise, so they have to ask their friends to borrow the tools, they have to work with the partner to cook the meal. So they're practicing those individual skills in that group setting. Um, and that could be said to be true of people in an inpatient stabilization situation. You may not have planned out an individualized treatment plan, but you have enough information, or you can ask questions about what do you want to get out of group today? What are you really working on? Or if they don't want to engage, sometimes them showing up and passively participating is, a means to an end as well. Um, I think as occupation based as we can be is the best route, meaning, you're practicing anger management in an actual role they would have, a setting they would be in, something related to their everyday life. And sometimes groups just help people. They feel less alone, they engage more. In your work, like if you can get someone out of their room and coming to group, it can mean a lot and it can build momentum.
Definitely. We have some people where I work who like they do not engage at all,
Mhm.
and it's just really tough. And my partner, she's wonderful, but she came up with this idea of like, oh well, like maybe they'll, even though they don't talk to us, they don't leave the room, they don't get out of bed, they don't come to groups, maybe they'd like to like look at magazines. And so she started bringing magazines to people, and like they actually were like, oh yeah, and started
Yeah.
looking at them, and like just like that little thing, we're just
Hmm.
like, wow, like I feel like that's pretty significant.
Yeah, and that's also
So
something they would do at home.
mm-hmm.
It's something people might engage in. So is
Yeah.
journaling, so is exercise. I mean, I think the clinical world can make us feel like we're not doing OT, but the reality is occupation exists everywhere, whether someone's ill or unwell
Yeah.
or they're perfectly healthy. And so, that magazine and having it may have made a big difference.
Yeah.
It feels normal. It feels like everyday life.
Kind of just like humanizing where they're at
Yep.
too a little bit. They're in like this strange place away from home. They
Yep.
don't want to be there. Yeah, and
Yep.
just bringing a little bit of normalcy, I
Hmm.
think, is big.
Hmm.
Um, a little bit. And I wanted to ask kind of your opinion on what the difference is and um, how it looks whenever occupational therapists in more traditional settings practice mental health strategies versus psychosocial OTs, and like how different are like the interventions and the
Mhm.
processes they use, goals and all of that.
Yeah, I think in settings that are more physical rehab, so like
Mm-hmm.
inpatient rehab post surgery, or helping someone live with a spinal cord injury or a traumatic brain injury, there's psychosocial and mental health all over that kind of situation, but the setting's going to limit, you know based on reimbursement and health insurance policy and procedure, what you can and can't do. But there are going to be things you do as an OT that you may not be targeting a mental health diagnosis or challenge, but you are bettering that person's mental health and
Yeah.
well-being. So somebody with a spinal cord injury being able to gain enough strength to transfer themselves in and out of a wheelchair so that they're not dependent on other people. I mean, that's huge. And that is a psychosocial benefit. You're just not in a mental health setting doing that for someone with maybe a diagnosed mental health challenge, right? So you're still doing OT for that psychosocial benefit. You're just not an OT in a psychosocial setting, if
Mm-hmm.
that helps, right?
That does make
And I,
sense. Yeah.
I think it's important for all OT practitioners to remember, we started in mental health treatment. That's where OT comes from. And B, again, it's that doing. So if someone who has had a traumatic life event, like getting a spinal cord injury, can be more independent and feel self sustaining, they're going to feel better about themselves. And if they feel better about themselves, they're going to have the protective factors in place to prevent mental illness or mental health challenge. So it is, again, something that can be boiled down to or distilled all the way down to that psychosocial piece, right?
Mm-hmm.
And on the flip side of that, maybe it's someone who, again, spinal cord injury, but they don't necessarily want to be not, they maybe want to be able to rely on their caregiver. So you're helping the caregiver have enough strength and stamina and mental health to care for that person, and navigate what that relationship looks like now and how they get around, the world. So I think if you can help the client achieve what they're trying to achieve, whatever level of independence that is, you are benefiting their mental health. Versus, in a more traditional mental health setting like where you work, Jessica, your goals that you're working on are going to be about symptom management and being able to discharge back to the community or back to their living situation. So you're going to see some more of those traditional mental health interventions like group settings, where you work on, managing your symptoms or knowing what your early warning signs are, um, taking your medications, those kinds of things. I think the outcome is the same. It just, the path you take to get there looks different depending on the setting and the diagnoses you work with.
I think a follow-up question to that would be, so in many settings, there's kind of, I would say, like specialized skills that OTs develop and utilize. So some things that come to mind, let's say that you are a certified hand therapist. Some of the special skills you'd have might be like creating a lot of orthotics, like complicated orthotics, and then obviously like very skilled in anatomy and knowledgeable in anatomy, and the structure of the hand, stuff like that. And I'm sure I'm diluting it. I'm sure certified hand therapists do much more.
So much,
But
but
just
they
like
do have that specialized skill set that you're talking about. Yeah.
when I think of pediatrics, I think of a specialized skill set, is sensory integration, stuff like that. Um, and so when I think of mental health as a specialty, I wonder what is like our specialized skills and what do they look like compared to OTs in different settings, do you think?
Yeah, that's a great question. Um, there are three things that really stand out to me. I am not, a board certified mental health specialist through AOTA or anything like that. So this is just all based on my kind of clinical experience over the last
Mhm.
decade. I think one thing that we become specialized in as OTs that work in more traditional mental health settings or with those people who have real serious mental health challenges, we're really skilled at intervening at the environment level, um, particularly environments that are much more socially structured. So places like work, school, community, being able to help the individual learn how to adapt their own environments. Whereas in some other settings, we might actually do those adaptations for them, like put in grab bars or give them a tub transfer bench, right? We're going to be giving them skills to advocate for what they need and to be able to adapt their own environments. So I think we're kind of specialists in environmental intervention when it comes to
Hmm.
mental health, which gives us kind of this superpower, I think, because then we make it so that it's not about what's wrong with them, but about what they can do to control their environment to live with their illness. Um, and I think there's two things on top of being environmental specialists that help us do that really well, that set us apart. And those two things are cognition and sensory processing. So a lot of our assessments in OT are not necessarily about what's wrong with you, but more about where you fall in this general sense of skills or processing abilities, right? So the
Right.
sensory profile, the adolescent adult sensory profile, it allows me as someone's OT to understand what their processing needs are and maybe where they could focus some attention to be able to navigate their everyday life more easily,
Hmm.
and to use sensory processing more functionally. So being able to understand that maybe they are sensitive to auditory information or they miss visual information more often because of their processing patterns, being cognitively aware of that helps them pay attention to different things in their environment differently. And many people with mental illness have extrasensory symptoms. They see things that others don't, they hear things that others don't. So they have to learn to navigate this sensory reality in conjunction with the other reality they may be experiencing. And I think we can help them do that in a way that reduces self stigma because of our attention on sensory processing. Like, there isn't anything wrong with you, there's just these things that you need that you're
Right.
not really able
Yeah,
to get right now. Does that make sense?
that definitely makes sense. Yeah.
Yeah. And then with cognition, we help people with mental illness problem solve because problems keep coming even if their brain is struggling to do that. And so maybe you learn to problem solve by compensating, or you practice and practice and practice and you're able to do it well again. So I think that cognition piece, um, whether we practice it kind of more tabletop, so to speak, with different activities or playing games, but then we can generalize that out into everyday living, that functional cognition piece. I mean, I've worked with clients where I've seen them do something like the Allen's cognitive level screen at a 6.0 level, but
Hmm.
then I'm with them in their own home and their symptoms are such that they can't even make themselves a sandwich,
Yeah.
right? So if you didn't see them in their real life environment, you would think that they don't have a cognitive challenge. But when it comes to living everyday life to meet their basic needs, they really did. And so as an OT, I could help problem solve that for the client, the team that was helping them. Like, what does this mean? They're performing well to this test, but when it comes to getting themselves food or living everyday life with what's acutely happening to them, it's really, really hard.
That those are really great examples, and honestly, for me, it clarifies some things up as well because I think in my time I've spent in my job so far, I'm kind of like, well, we have like different people running groups. Like it's not just OTs that run groups, but like what sets me apart and like what skills do I have that are different than I guess other people running groups, and trying to like distinguish that in my mind and then build on those skills. Um, so yeah, definitely. I think that sensory integration would play a big role in mental health. And yeah, cognition as well,
Yeah. Yeah,
including all the other things you said. But yeah, no, thank you for that.
yeah,
Um,
definitely.
so another question that I had was kind of bringing it back to more traditional settings. Um, Obviously, you said that us kind of like doing things, right, supports the overall mental health of the client, which I completely agree with. That makes complete and total sense. Um, However, when I kind of think of other practitioners and other disciplines, so like physical therapists,
Mhm.
and um, I don't know, physical therapy is the only thing on my mind right now, or like speech or, other things. What I think sets occupational therapy apart in regards to providing that mental health piece that maybe other disciplines might not have, or like what makes us qualified to support mental health, maybe more so.
Yeah, I think a couple things. Like from the educational side of things, there are certain standards that every program has to meet around psychosocial or mental health objectives in a fieldwork experience of some kind, which then means it's in a class or two about how to do the OT process with people when you are solely targeting those mental health challenges, diagnosed or not. And social determinants of health, that's not something that is outside of the realm of mental health. And what I mean by that is, people come into physical therapy or OT in an outpatient setting who maybe they have habits that are not as great for their mental health as some others, whether that be, alcohol consumption, substances that they use, occupations that they engage in that maybe aren't benefiting them.
Mm-hmm.
So, and then there's systems in place that put them at greater risk. They maybe have low income jobs, or they, are a person of color that lives in a poor neighborhood and they need, more services than they can get. I think OT's brains as individuals and clinicians tend to go to those bigger systems pieces and
Mm-hmm.
what are the environmental barriers to being able to meet your needs, whereas someone that's maybe more of a physical therapist or a rehab aide or, even a doctor to some degree, they're really focused on managing the problem at hand.
Right.
So, someone with diabetes comes in with neuropathy and has limited mobility. Well, that there's many ways you can treat that, but what do you do for that person who has that and, lives on a third floor apartment building that doesn't have an elevator, who also is on food stamps and only works 1 day a week?
Mm-hmm.
Those kinds of real life problems are not always considered by every other profession. I think there are individuals within each of these other professions that do think that way, but practice settings dictate a lot, and OTs are
Yeah.
trained to look at the big picture, pick a smaller piece of it, work on it for a little bit, and put it back into the big picture and see how it helps that person. um, I don't I haven't seen that happen a lot in my limited experience in the physical rehab world, for
Mm-hmm.
example. There's a lot of things within OT where they talk about, like, PTs can teach you to walk, again, but OTs help you walk to the refrigerator or dance with your granddaughter or whatever it may be.
Mm-hmm.
It's back into the context of that purposeful and meaningful role or
Yeah.
occupation that you have.
And I think you put it well, where it's not necessarily that like other professions can't, and some individuals in other
Right.
professions do support a more holistic view of the patient. But I like kind of your example of just like the training we've had. So like a lot of like the models in OT,
Mhm.
obviously, and like frames of reference. Our whole foundation is rooted in that holistic view of the person, and considering the environment and like what they need to do, and also their individual skills, and um, just considering everything, and then how is this going to achieve what they want to do, makes it more likely, I guess, that an OT would support the mental health needs. Does that make
Yeah,
sense?
yeah. And I
Okay.
know that I think there are physical therapists out there that are targeting the mental wellness of some people. I mean, like pelvic floor physical therapists. I mean, that's like a huge emerging field, and that
Hmm.
stuff is sensitive and vulnerable for a lot of people who receive those services, and that probably helps their psychosocial wellness incredibly. Um, but I don't think the foundation or crux of someone's training is the same as ours to help them really, they found that in practice. They didn't find that in school, maybe.
Like I said, I think you put that really well, and
Mhm.
I think that gives me like a new way of looking at it.
Mm-hmm.
Um,
Mm-hmm. That's good.
Cool. Another question I also wanted to ask, and it's a pretty generalized question, but how has working as a occupational therapist in a mental health setting kind of shaped your view of occupational therapy, and then also shaped your view of the mental health field as well?
Well, this may be where you have to find other times to chat with me because I could probably go on about both of these things, Jessica. I think the first thing, you know, um, I think I mentioned earlier in the session that I have always been really interested in people's mental health, their behavior, why they do what they
Hmm.
do. And I had considered things like counseling and
Hmm.
psychiatry. But OT was something that I think I've realized working in mental health has taught me that we come alongside somebody and we use our own experiences and our own life story to help other people.
Hmm.
It's that therapeutic use of self. We're able to match people and mirror them and help them in ways that I don't, I think there are probably terms in other professions, but I think that piece has really stuck out to me. That the relationship is really, really, really important. And working as an OT in mental health settings has taught me just how important that relationship piece is. Um, I think the other thing it's taught me is that there is a divide in our own profession of OT in mental health versus OT for mental health, and they are different. And the reality is, we're all doing that, even if your practice setting and your job description say you're not.
Hmm.
Um, we are helping people have positive self esteem and feel good about themselves and be resilient enough to live life when there are health issues or neighborhood issues or community challenges. That's our specialty. So I think it's taught me that we're all doing OT for people's mental health, even if it's not somebody who has a diagnosed mental health condition, and even more so now than ever before in a post-COVID world that has a lot going on in it. What was the second part of your question? Oh, go ahead.
Oh, so not only it changed your view of occupational therapy, but also how it changed your view of like the mental health field?
Mm-hmm. Mm-hmm. OTs are really good at transition and translation. So helping people navigate change and also moving information from one place to another, or from one way a person interprets to a different way that a different person interprets or takes that information. And so I think the mental health care system has a lot of gaps.
Mm,
It's very siloed. It is heavily underfunded.
mm,
Uh, and I think it has taught me that as a society, we don't value human lives that are mentally ill in a way that we should if we want them to do better and feel better. And that there aren't enough OTs, and particularly enough occupational therapy practitioners who want to work with people who are really mentally challenged, whether that be active symptoms of psychosis pretty regularly, or major depression to the point where getting out of bed is really, really hard. Um, yeah, I think that we need more OTs, and I think we also undervalue as occupational therapists our skill set in helping systems of care change and adapt and get better. If we can do individual goals for a person and they can feel good about how they engage again, I think we can consult with systems and help write policy and advocate for change. Um, you know,
Do you think there's a bigger problem with there just being a lack of availability for mental health jobs for occupational therapists? Or do you think that the problem is more just the lack of interest OTs have in mental health?
I think both of those play into each other and feed off each other a little bit. I mean, it's hard. It, COVID, as an educator in OT education, COVID really taught me how hard it is to find people who can volunteer their time to have a student or someone interested in becoming
Mm,
an OT student shadow them, right? So if it's hard to do that, but then there's only a few OTs and systems that are truly traditional mental health, then it's even harder to see it. So I think you have to see it to think that it's possible. That
yeah.
representation really can really matter, right? And every program chooses to do their curriculum differently. And so some schools have more of that focus and some schools have less. That's not bad or good. That's just how it is. Um, so I think there's not enough OTs in mental health to expose people to that potential. My other take on it is that it is highly expensive to get an OT degree. And so if you have debt that you need to pay off, because we don't right, because we don't reimburse mental health care systems the way we could and should, they're
Mm,
not appealing jobs financially. So that
definitely. It's kind
plays
of like
into
you
it
have
too.
to pick, do you want to make a lot of money or do
Yep.
you want to follow this dream and be poor?
Right, right.
But yeah. Oh, what was my other question? So, obviously it kind of goes state by state for like what states consider occupational therapists, mental health clinicians. Do you think that that kind of affects how occupational therapy programs in schools teach occupational therapy? Oh, or mental
Yeah,
health and occupational therapy? Sorry.
no, yeah, I could see how that is the case. Here in Oregon where I live, OTs by state law are considered qualified mental health professionals. So
Mm-hmm.
what that means is that a licensed occupational therapist and a licensed occupational therapy assistant, while they would be at different levels um, within the structure of that agency, they're still able to encounter and reimburse for the services that a peer support specialist or an employment person or a counselor or like a residential counselor would be able to do. So they're seen as able to encounter Medicaid dollars, which opens things wide up for who can
Mm.
hire an occupational therapist to or occupational therapy assistant to be on their mental health team at a community level. So what has happened here in Oregon is there's so many OTs and OTAs in those positions that there is more of a focus in educational programs here. I mean, at least up until now, there's only been one. There are more coming, but
Mm-hmm.
to prepare people for what that workforce looks like. So there is a more emphasis on mental health and how to support people's well-being and how to work in those settings and more field work opportunities because there are licensed OTs and OTAs in those settings to take those students. Um, so you can learn about it in the classroom and then you can learn about it in clinical education and then you can work in it. So there is kind of that pathway. I think in states where that we don't yet have that ability as OT practitioners, they're sending their students elsewhere,
Yeah.
even if their program has a strong focus on it. So I think it really is program by program. But yeah, I think those kinds of labels or statuses or credentials, they open doors. And I think if people are going to get the OT that they deserve to have access to, we need more of those doors available. I think it would be much better, of course, for an OT to be seen as an occupational therapist and to be able to bill private and public insurance for someone with generalized anxiety disorder, regardless of age. But we don't live in that world yet.
Yeah.
It is split up how it is split up. And so, and there are policies that are barriers to those things.
Along the lines of billing, because like this is honestly foreign to me. I have not looked into it that much. I just go to, well, especially for like where I work. In my role, how I understand OT to be billed is kind of like a lump sum.
Mhm.
So like I don't bill for like specific hours. So I kind of just like don't worry about it, which is bad.
Yeah.
But so like in Oregon, you said that occupational therapists are considered mental health clinicians, and they can bill for similar things that counselors bill for, or
Mhm.
maybe social workers. What, like more specifically, what can they bill for that they wouldn't be able to bill for in a state where they're not considered a mental health clinician or practitioner?
Yeah. So things like individual psychotherapy or the common procedural codes, the CPT codes that go with things like talk therapy, group skills training, individual skills training, case management, case coordination. In states where OT practitioners are not able by law to be considered a mental health professional, many of those OTs at a community level, like where I used to work, are grant funded or are part of a similar to your setting. It's like a bundled service.
Mm-hmm.
Whereas Medicaid is fee for service. So my individual sessions and what I did were billed to certain codes to get reimbursed for that time. Um, so that can really limit you. It can make it hard to see why you would hire an OT if you can't make money off of their services, right?
Yeah, yeah.
So yeah,
I could see the problem.
yeah,
Yes.
yeah. I mean, there's pros and cons either way, but that is an example. Like my services were all encountered very similar to my counterparts that I worked with. And then, where I could bring in the most income was with my evaluations. Um, and there were codes, and those are across the board. The OT evaluation codes are separate. So it was almost like I lived in both worlds. Like I could
Yeah.
do treatment alongside my psychology and social work peers and make money for all the work and what I got out of that evaluation that maybe wouldn't have gone further than a consult with the team if I can't do the individual or group treatment.
So with that, even diving in a little bit more and being a little bit more specific. So, utilizing things such as like CBT,
Mm.
DBT, those type of skills that are seen more so, I think, in like mental health professions like counselors
Mhm.
or, more like that talk therapy. So in Oregon, where occupational therapists are considered mental health practitioners, um, they can bill for using those modalities.
Yeah.
Yes.
So yes, yeah. So like if I ran a group that used cognitive behavioral therapy, my services were billed out that way by the billing team
Okay.
that was part of my agency. Or if I was in private practice and I was credentialed appropriately with Medicaid, then yes, I could bill for those services. I wouldn't bill for dialectical behavioral therapy unless I was more trained in it. That's just my
Okay.
professional, ethics. But there were times that I did CBT quite a bit with people, but we were also engaged in roles or routines or occupations that they were trying to work on. So I helped young adults using CBT and occupational based interventions get their driver's permits or perform better in school or apply for jobs, look at
Yeah.
colleges, those kinds of things. And so you know motivational interviewing was something I used a lot, and that's from the psychosocial, like social worker worlds too.
Yeah. Because I'm just trying to make it make sense in my brain.
Yeah,
And hopefully this is
somebody else's
questions
brain.
other people have. If not, maybe it's just me. But um, so I guess I'm trying to also like make it make sense as well, where CBT is typically talk therapy, which is kind of what we don't necessarily do. But if we're utilizing a skill or like a modality that is traditionally seen as talk therapy, how do we make it functional, which is like what you were kind of talking about, but I want maybe a little bit more of a concrete example of what it would look like, um, if
Yeah,
possible.
totally. I think kind of back to how I explained it often to my fieldwork students. So you're not going to run a session with someone as an occupational therapist without talking to them. And you're
Hmm.
probably going to try to engage with them in a dialogue that is therapeutic. So asking them like, what is hard about this? Or why are you hesitant to try a new thing? And all of those things challenge beliefs and thoughts that they
Hmm.
have about what they're trying to do, right?
Hmm.
Um, or with motivational interviewing, you're asking a lot of open ended questions to get them to hear themselves talk with change talk. So, like an illness recovery group that I ran, we would often talk about smoking cessation because it is known that certain medications are interrupted in their therapeutic benefit because of nicotine and smoking. And so being able to have a conversation with them that is therapeutic around why do you smoke now? Do you want to smoke in the future? What would your life look like if you didn't smoke? You know, do the medications benefit you? And if they do, why do something that interrupts that? And that's that like psychological talk therapy piece, but we're
Hmm.
still grounding it in the many activities and occupations of managing your illness.
Right.
Does that make sense?
It does. So,
It's just one tool that an OT is using
yeah, yeah, yeah,
among
yeah.
other tools. Whereas, like, if you or I went to a counselor, there'd be a lot of talking back and forth.
Hmm.
We wouldn't be able to necessarily get to the part of putting that outcome of that session or how the CBT benefited me into practice. Whereas
I
an
see.
OT, I can do those simultaneously.
Okay, or maybe doing like one session where like you're talking
Uh-huh.
about it and then the next session, okay, like let's put this into
Right.
more practical use.
Yeah. Yeah.
Okay.
Yeah.
Yeah, no, that makes sense. Cuz I kind of struggled like, well, if we're both doing CBT, ooh, how are we different and how
Sure.
ethical is it that OTs use CBT or DBT or ACT or all that stuff? Cuz like
Yeah. I
that's
mean,
what
I think
I've
if
been
you're,
struggling
yeah,
with. Yeah.
if you're trained in it and you can use it and you can stay true to the scope of occupational therapy, there's nothing wrong with that. It's probably benefiting people because, again,
Okay.
it's just one tool in our toolbox. And people face challenges when they engage in occupation. Like maybe someone's doing something where they come up against a fixed belief about their ability or how they look or what the outcome's going to be. And you have to challenge them in that moment so that they stay engaged and meet that goal.
Yeah, that makes a lot of sense. I think the way you explain it really clarifies a lot for me because I don't think anyone's outright just said that these type of modalities are modalities that can be used across like a spectrum of disciplines. And I think
Mm,
to me, it's always been like, oh, like we can't use those because we're not counselors or we're not psychologists or
mhm,
psychiatrists. So
mhm.
that clarifies a lot of like it's just like a tool in our toolbox that we can use or other people can use, but at the end of the day we are targeting things a little bit differently or we're targeting different things than other people might be.
Yeah, our
Okay.
process, is different and the things we're looking at and what we're trying to make work differently. And yeah, but again, yeah, I think it's about how we use those tools to help people engage in occupation versus, able to manage their symptoms and feel less anxious.
Yeah, so it's more you can use these modalities but
Mhm.
make sure that you're properly trained in modalities
Yeah,
before you use them.
right,
Kind of
right.
just like if you're like in hand therapy using like an ultrasound machine or like something
Totally.
like that.
Yep. Yeah. Or
Okay.
you get specialized training and, some kind of biofeedback for people with,
Mm,
um, you know, I don't know, traumatic injuries from falls or whatever. There's all kinds of things that people get specialized training in. So
yeah.
I think, yeah.
So I want to change gears a little bit and then move on to talking about addressing the practice research gap, which I know that I'm pretty sure your dissertation was on that for your PhD, correct?
Yeah, it was my PhD was in translational health sciences. So it's all about those
Perfect.
gaps and how we overcome them.
I picked the right woman for the job.
Let's hope so. Let's hope so.
um, okay, so I think my first question would be um, what hmm, what are some of the barriers you see, first of all, in translating research to the practice setting?
Yeah, I think a couple things. I think as a clinician, it's really hard to find time
Mm,
to read and digest and understand new evidence that's coming out. I also think we easily forget that we were trained in an evidence-based practice and that if at the end of the day what you have done is observe somebody functioning as a licensed OT or OTA and made some recommendations, that's still skilled therapy because you have the degree and license to prove it. So I think time can be a challenge. I think interest and people's comfort level with research. I also think that not enough emphasis on the research side of things has been about making it make sense to everyday clinicians. I sometimes like to talk about it as practice based evidence instead of evidence based practice. There is a lot that happens day to day for clinicians that gets lost in the way research is done. And so clinicians or agencies or hospital systems that want to partner with researchers or clinicians who become researchers or do both practice and research, they can help really bridge that gap and overcome some of those barriers. But I think time is one of the ones I've seen the most in my own experience, that I heard the most from fellow OTs and clinicians of all shapes and sizes, every background of practice, and that it comes through the research too on why people struggle to use evidence in practice.
Yeah, and I mean, I can personally attest to that, and I don't even have to keep up with like productivity standards where I work. So, which like, don't get me wrong, like I'm busy all the time, I'm doing things, but I could only imagine if I'm working at a place with like 85, 90% productivity, like,
Yeah.
are you supposed to like research off the clock and like your at home life is taken up by like
Right.
researching
Right.
and then you're working? Yeah. So, like, I could imagine setting has a big impact on time, but like, I guess what are your thoughts on like overcoming that and like what are some solutions to address that?
Yeah, I think one of them is what you're doing, Jessica. Like podcasts really help people get information at times when they are not focused on much else. So someone
Mm-hmm.
driving to work could listen to the AOTA, American Journal of OT Evidence-Based Practice podcast. They have sessions all the time. Or they could listen to this podcast, or there's the uh, Dr. OT's podcast with a couple professors out of UNC. Like there are so many different OTs that are either practitioners or faculty or both who are doing this kind of work where they're presenting information and evidence out to people in a more engaging and interesting way. So there's podcasts are a great way to get it. I think there are um, ways to get evidence faster through if you're a state member of your state association or the national association. They have those special interest section quarterly newsletters that get emailed out or sent to your house. OT Practice is a great way to
Mm-hmm.
get information in a way that's like reading a magazine instead of reading a research journal,
Yeah.
right? So it makes it easier to get, easier to digest. I think going to conferences, although they can be expensive and time consuming and not everyone has the ability to go, they do allow you to get that evidence and a lot of it quickly, so that you can take it back to your job.
Really
Yeah.
good. Um,
And the American OT Association has a new knowledge translation toolkit where they kind of give members ideas on how they can bring new evidence to their work and how they can champion it. So, how to find research and how to get other people interested in it. Things like lunch and learns or journal clubs, book clubs, or something a lot of people do. Um, because again, I think there's lots of ways for OTs to learn from newer books about things related to mental illness that aren't necessarily written by an OT, but might help your practice be better.
Makes sense. So, I guess just clarifying this tool on AOTA, is it kind of like suggestions for
Hmm.
like how you can? Oh, okay.
Yeah, so they have different tabs on the web page for different things. So, like, how do you find evidence if you work somewhere where you don't necessarily have a journal access or a database access?
Mm-hmm.
How do you start a journal club at work? How do you, have conversations with people that you work with to get them interested in bringing a new product or a new intervention into your establishment. So they have different ways of approaching it, kind of across this continuum of ways you would do it.
Okay. That's a good
Yeah,
idea.
yeah. And
Yeah.
again, I think podcasts are a great way to do that. Books. I listen to a lot of podcasts, and I listen to a lot of recorded books in the car. And it helps me get that information, and I don't have to take up a lot of time in a different part of my day to get what I need.
Exactly. Yeah. You're in the car anyway. So,
Hmm. Hmm.
yeah. It's either podcast or the new Taylor Swift album.
Right, 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 right. Flip back and forth,
Right, right,
that kind of
right,
thing.
right.
Yeah, yeah.
Yep. Okay. So you said time and then I guess digestibility
Mhm.
of um, the literature, um, which you spoke on a little bit with the AOTA magazine that they release each month, podcasts, and then that new function on the AOTA website. Are there any other, I guess, ways that you could make, I guess, accessing
Mm.
literature more digestible or less, I would say, intimidating?
Yeah, I think there are places to get what's called open access. So the researchers have paid for it to be available for free and to anyone who accesses it. And a lot of those journals are starting to do these things where they have little boxes on there of like, what's the key takeaway from this? What's
Oh,
most
yes, yes.
relevant? So, focus in on those things that are more applicable or something you can apply in every day. Um, that way you don't have to necessarily spend, hours digesting or reading the research, because unfortunately so much of what gets published in peer-reviewed journals is really meant for people who are doing that research as well or in that line of research so that they can understand where that scientific knowledge base is going. But I think to more and more, I'm seeing journals ask for the researchers to say, what does this mean for the everyday person? What does this mean for the clinician? What does this mean for the policymaker? And be able to give them a little carrot of something they can use, right? Like, you may not be able to interpret what the Wilcoxon rank test or statistical analysis they used means, but you can take those 3 points and start using them at work or,
Mm,
looking for new information. I think also another way for clinicians to get access to the most up-to-date research is to take students, because students come from
mm,
academic institutions where they have access to that, and they can bring you those papers, and you can have them do an in-service, and you can have them educate your team. Students have energy, they have stamina, they have passion and interest. Not that we all don't either, but they're like ready for it, right?
yeah, yeah.
And everyone wants to be valued and bring something valuable to where they are. So I think that's something I would say could help bridge that gap too. And I know it's a lot of work to take students, but it's a win-win for you as a clinician and for the profession to have students come.
Honestly, when I was a student, I was like, well, I don't know like what I could bring to the table, and like I feel like I don't even know what I know, to be honest. I feel like I don't know anything. I'm just showing up. But I think like hindsight, um entering into like the workforce now, I'm able to more clearly see the benefit for sure.
Mhm.
And I think especially like working at like a state facility too. Um it
Yeah.
Yeah, like huge benefit to having kind of like new blood come in, bring in
Mhm.
new energy, bring in new ideas. Huge, 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 huge. So
Yeah. Yeah.
yeah, it's
Yeah.
funny how like the way you look at things changes whenever your role changes.
Yeah, totally. I mean, again, another argument for occupational therapy.
Mm,
When your roles change and things, yeah, expectation changes, you have to adapt,
yeah.
be able to
Um,
perform accordingly.
I think I'm kind of torn a little bit, and I want to know what your thoughts are, because I am a skeptical person, and I don't really, if someone tells me something, I'm not going to believe them until like I find the evidence and I read it and I understand it. So that might be like a personality thing for me. Um, as far as like evidence goes, like if someone's like, oh, well, this is evidence based or blah, 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 I'm like, well, show me the paper and let me read from the first word to the last word. And I have to understand everything. And like, so then I just get so overwhelmed, first of all, because I'm like, oh my gosh, I'm using the dictionary or like my evidence based book every like 10 words. So this is taking me 2 weeks to get through this paper. But I guess how important do you think it is for clinicians to work towards being competent in reading literature and understanding literature? Or do you think that it is enough to, um, if there is starting to be a shift where it's kind of like just like presenting the bullet points, taking those bullet points at face value?
I think the most important thing is for the clinicians, for us to know how we best receive and learn
Mm,
information so that we can stay up to date, not only for our clients and ethical practice, but so that OT stays relevant. Because every profession shifts over time and new things are added. But also don't forget that occupation is evidence based, and we have been here. I mean, we're a younger profession, but we have value and we are making evidence and we are changing lives. So you can't forget that still exists. But I think there are unique ways to get information these days. Whether that be, like I mentioned, a podcast where someone has read the research and they share it back out with you in a different way, or you read something in OT practice because it's shorter and easier to read.
Mm-hmm.
Or you start a journal club with friends and you each read a chapter and teach it back to the person instead of, having to read the whole journal yourself. You break it up into chunks. I think it's important that people know how they learn best and how to engage in that occupation of staying evidence-based as a clinician so that you, um, when people ask, can explain why it is OT or why it is skilled or why occupation matters.
Yeah. I think my only fear is like if let's say like I am utilizing like certain podcasts, or if I am, let's say, breaking up, like I have like a journal club and we're like breaking up certain sections. I feel like with a podcaster, if they're doing the work to read the research and understand it and translate it, you're kind of putting a lot of faith in them being able
Hmm.
to understand it and
Hmm.
translate
Hmm.
it. And so
Hmm.
like you're getting their point of view on the translation of the paper. And also like if you're like breaking up like a journal, I feel like sometimes if you don't have a lot of like the skills to understand, or if you're not pursuing to understand literature, then and you're in a role where like what you're saying is affecting like other people's practice, you misinterpreting something, I mean, hopefully it wouldn't have like huge implications,
Right.
but
I hear what you're
it's,
saying, though. I
yeah.
understand. Yeah. I think that's where it comes down to maybe. I think there a couple things come to mind in hearing that scenario, Jessica. I think folks can treat it kind of like a book club model where everyone reads the chapter and then you just kind of have a leader facilitate the discussion. I mean, I've used that in my own classes I've taught as an educator.
Mm-hmm.
Um, the other thought I have is that there are ways to, I mean, this is going to sound rudimentary and I don't mean it to be, but like you can speed read an article to get the gist of what they're saying. I mean, I had to do that a lot
Yeah.
in my PhD work to be able to learn enough from the reading to keep up with discussion posts and, be able to think critically through things. So, I learned kind of early on in that doctoral journey to, read the abstract, and
Mm-hmm.
then I would read the conclusions, and then I would go back and read topic sentences and like try to get the main points.
Mm-hmm.
Granted, this was my full-time job, was to read research and digest it. That's not something everyone wants to do, and I even struggle to do it now, and it's still part of my job. So I think that's just finding ways to do it either individually or in a group that serve you and benefit you, and also reaching out to resources and people so you don't feel so alone in that process, right? Like maybe it's hard to find people you work with who want to do this kind of thing. So you start it with a friend that works at a different agency, or, you
Mm-hmm.
know, I think this is where being a member of your state and national association can be very beneficial because they can offer things like communities of practice or special interest sections like what AOTA has. Or here in Oregon for OT Night Out, we have, or every month we have what's called OT Night Out, where different OTs and OTAs congregate somewhere once a month and talk about how things are going. So I think
Hmm.
just, to try something new, you have to feel like you have community and people you can talk to about it too. So I think state and national membership in those associations can really help. And they can get you that information in a distilled and quick way
Um,
so that you don't have to do all that legwork. You're
yeah, I
paying
don't know.
somebody
I'm
else to
pretty
do it. Yeah.
stubborn though, so I still probably will be like, oh, let me fact check
Right.
everything you just said. I'll get
Right.
back to
And
you in
there's
2 months. I have
there's
a
going to be other
problem.
people. Yeah, there's going to be other people that are like that too. But,
Yeah.
there's roles for them too in these associations and places. I mean,
Yeah,
look at what you're doing with this podcast, You're putting it out for other people.
true. It's
So,
also, I just aspire to be famous. No, just kidding. Typical millennial, right? Um, so, and I feel like we kind of talked about it a little bit, but I guess just more so in depth, just like strategies to start integrating practice and like what does it look like? So like you found literature through AOTA, or you found like evidence through a podcast, through the OT magazine, wherever you found it. Go about starting to shift that into practice?
Yeah, that's a great question. I can kind of, I hope, answer it with an example. So when I started in my clinical job at the Community Mental Health Agency here in Oregon, there was a group that I had um, facilitated and done research on when I was in OT school, and it was all about like helping people make healthier decisions around food and exercise who were
Mm,
living with serious mental illness. And so I had an interest in it, and I knew that there was a robust set of groups that my agency would offer every few months, right? So there were always groups every day going on that people could sign up for. And so I asked if it could be considered in the options. And so when I approached my manager about it, she had questions which I planned ahead for around like, what's evidence on it, how would it work, what do you need resource wise, would there be extra cost to this, and I had done my research ahead of time in terms of what was being currently offered around nutrition, exercise, and other things at this agency. And so it'd be like a cooking group, but it also adds in things like how to shop healthy on a budget, or ways to incorporate physical activity without a gym membership into your everyday life. um, and it was a manualized curriculum, so there were no extra resources. I had what I needed to get going. So for me, it worked out in that instance to take my interest to my program manager once I had a full understanding of what everyday groups were at this agency already.
mhm,
Um, if it's a brand new intervention that I wanted to try with a client, I would probably approach it with kind of the same plan. Like, here's what I know about it, here's what I've learned, here's who it could probably benefit, and why don't we pilot it, so that it doesn't get full blown,
mhm,
scaled up right away, because that would help you build momentum and have other champions who want to help you do it too. So a new group idea, a new individual intervention. Um, I think some of the things I found the hardest were to build momentum around kind of the ideas we've been talking about, like would someone be interested in a journal club or a book club, or taking your free time to meet with a group once a week and talk through these different ideas. That's sometimes more challenging, but I think those are some of the tips I would give, is just approach it with a solution to the problem you're already identifying. Does that make sense?
mhm.
Like,
Yeah. Yeah.
there's a gap here, here's what I see could be of benefit, here's what I know, and here's how much it might cost in time and resources and money. Would you let me do it?
Yeah. And that sounds a lot like what we do for our capstone projects. So we're
100%.
already trained to do that.
Yeah,
Um,
you're doing it with clients every day.
yeah.
What do you have? What do you not have? What do you need? What's the current landscape, and how does this fit in?
So with that though, that seems also like a lot of work.
Yeah.
So
Well,
like how do you um and like with that kind of like talking about, oh, we have like limited time, but when we want to utilize certain things in evidence, like proposing it and like kind of creating that proposal and that plan and like doing your due diligence, um I could definitely see that workload and the time it takes to do that deterring people from actually
yeah.
pursuing it.
Yeah, that's true. That's true. I think my job's pretty similar to, or was at the time similar to what you're dealing with now, whereas like what groups are offered, how the day-to-day treatment m- operates.
Hmm.
It's not something you had to teach yourself necessarily. So I knew what the groups were, and I knew where it could fit. And so it was really me just being, I guess, brave enough or stubborn enough to propose it
Both,
and
a little
see
bit of both.
a little bit of both and see what they thought. And I was willing to do the work. Here's the other thing, like, I think my manager knew that I was interested in it enough that I would make the group happen. I would run the group.
Mm,
I would do all those things.
that
So
makes a big difference. Yeah.
yeah, yeah, yeah. I was a champion for it in and of itself. And then other people bought into it. The clients liked it. And so they brought it back. And it was manualized. It didn't require a ton of resources. It's something that was available on the internet for future people who would lead the group that weren't me.
Mm-hmm.
You know,
Mm-hmm.
so those kinds of things. And I knew about it from school, so I didn't really find it, on my own, so to speak, once I was in practice. So I think because it is a lot of work, it has to be something you're interested in doing, not just because it's new evidence, but like, is it interesting? Would it benefit your clients and would it work in your setting? Why or why not? You kind of have to make a pros and cons list to
Yeah,
begin with.
that makes sense.
Yeah.
Um, and I kind of just thought about this as well, like with continuing education.
Mm,
I feel like, and I don't know if this is just like how I feel or if this is actually what it is. But with continuing education, I feel like in the mental health field, it might be harder to find quality continuing ed for
mm,
occupational therapy. Is that, I don't know if that's true or not, but for me, I've been struggling to find continuing education for OTs, for psychosocial OTs that's like maybe a little bit more hands-on or like robust training, which obviously like continuing education does is in a sense like adding to like that evidence-based practice, like enhancing skills, all of that. So like what I guess would your advice be on
mm.
finding quality continuing ed for mental health OTs?
Yeah, that's a great question. I think first and foremost, kind of start with what's close to home. And so, like, what trainings might be offered by your employer that seem relevant to your practice? Not that you have to do every single one, but um, like, I got trained in this type of family intervention that's done at a group level. I got trained on CBT for psychosis. And these were things that were offered where I worked and they were of interest to me. And I was working with clients where that would benefit them. So I decided to do it. Um, so that's one thought I have. Um, the other I have is that, again, I think continuing education courses that are offered online or through some of the OT journals we might be more familiar with, like AJOT or the Canadian one or the British one. If you are a member of AOTA, you can get those at a discounted price and you can do them from home whenever you need to.
Mm-hmm.
Um, I think there are some newer and more innovative ones coming out. A few years ago, I peer reviewed an OT who was making one about OT's role in suicide prevention. That's relevant to everyone. It's
Mm-hmm.
psychosocial in nature. So I think you can find those through those associations or other organizations that serve OTs. I think another place that kind of catalogs those continuing education opportunities, there's an OT by the name of Sarah Lyon that started OT Potential. She has a podcast. She has some CE catalogs of trainings that are available to people. So there are these resources out there, and they're a little bit easier to find through social media now than they used to be.
Because
And
I feel like,
conferences. I mean,
oh
I think
yes, yes,
if you go
conferences.
to your state or national conference for OT, you'll get all the CEs you need
I
and be
wanted to
around
go.
other OTs. You
Yeah.
know,
Cause
yeah.
and that's what I was gonna say too, is like a lot of like the mental health continuing ed that like I've seen or that is sent to me is not OT focused, which is
Hmm.
okay. But I think especially as like a young OT in the field, I really want to at least start and like ground myself in like OT training. And
Hmm.
then maybe I can like cherry pick from there like
Hmm.
what more broad, maybe not as OT focused training I want, if that makes sense.
Yeah, totally. I think to find those things, you want to look in OT based resources. So, associations or other places where OTs have um, kind of band together to produce that information for people. That there are continuing education businesses that employ OTs that you may be able to find that content. Another plug I would make is that starting in 2017, AOTA has done these mental health specialty conferences every 2 years, and this year there is one of those happening
Oh, okay.
in Illinois in October.
Oh,
And so, just another thing to think about is I think if you're looking for OT specific, you're going to have to look within those kind of OT associations.
yeah,
Um,
that makes
and
sense.
there are more of them than just your state and the national, but yeah, that's a good place to start, at least to find people too that might know where you could get that kind of continuing education.
And another question kind of goes back to something you were mentioning earlier. You were kind of talking about maybe like clinicians partnering with universities to maybe like conduct research. So what would that look like? Because that's very intriguing to me. And I don't know if like clinicians know that they can even like do that.
Yeah, I think there's a couple ways to approach it. I think it could come organically from maybe you take a fieldwork student from a regional or local to your state OT program, and they happen to have a faculty member who's interested in what you're doing. Capstone students can often be a great place to build those kinds of relationships because they're not there for more of that clinical training. They're usually there for something else like program development or advocacy and leadership, those kinds of things. Also, this is just me, but if someone emailed me with an idea and they were a mental health based OT, I would definitely meet with them and hear them out and see what we could work on.
Mm-hmm.
So I think there's lots of ways to be engaged, or at least to reach out to get engaged in that kind of research. I think also it's setting dependent. Some people are working in hospitals that are part of teaching universities or research universities, right? And so that's more accessible.
Like let's say in theory, I reached out to you and I said, hey, I was thinking about implementing sensory type
Yep.
treatments in this setting. We don't have it right now, but I want to maybe do this intervention. But like I don't really know
Yeah.
like
Yeah.
how
I
that
think
would look like in research. Yeah, like what would your role be? What would my role be? How would
yeah.
we?
I think it could be, I mean, I am a capstone coordinator right now for the program I work for. So I would go to capstone. I would see if maybe there was a student who could partner with you and I could be their faculty mentor and you could be their site mentor. They could bring some of that experience and those resources to you. And they could help you pilot it with a couple clients or run a group that is sensory based and you could do a pre and post
Mm-hmm.
survey, and then that academic institution holds all of that IRB liability, right? The research
Ah,
approval
yes.
piece.
Mm-hmm.
Or maybe it's something that's of interest to your manager and they want to build out different programming. So you take a capstone student from an institution and they help you plan out an entire sensory processing group protocol of some kind. And then they leave that with you and you can run it again and again. And then when you're ready to research it, you can research it.
That's pretty cool. And
Yeah.
I didn't even like consider that as an option, but that makes a lot of sense.
Yeah.
Students are more valuable than I realized when I was a student.
Yeah. Yeah. I mean, that's how it goes too.
Yeah.
Yeah. That's pretty normal.
Hmm. I'm sure you have a lot more to say about this. I don't know what questions to ask. Those were kind of my questions, but if you
Okay.
have like more things you want to fill in with uh utilizing evidence in practice and whatnot, yeah, go for it because I don't know what I don't know. So,
Yeah, totally. I think I would just wrap it up around that topic by saying, like, it can be intimidating, but I think that it's even more intimidating when you feel like you're the only one who has an interest in it or
yeah.
you're the only one doing it. And it probably would turn out that you're not. And so I think, being able to reach out to OTs or your prior faculty that you felt like you had a connection to, or, someone um, that you work with that is a champion of OT and wants to help with this idea. I think just getting started is the trick, and there's ways to find it to make it work with your everyday life, to take in new evidence and try something new at work. And I would also say don't forget where you come from because the profession is evidence based to begin with.
Yeah.
Yeah.
Thank you.
Yeah, of course. Of course.
Well, like I said, I've really appreciated talking to you. I feel really lucky that you agreed to be on here. And like, even if you weren't wanting to do the podcast, like just talking to you and being able to like kind of hear like your points of views on things has definitely given me a lot of new perspective as a young OT. And hopefully other people who listen to this or watch this can take stuff away from it as well. So thank you.
Yeah, absolutely. I'm really glad you reached out, and I'm happy to be here. And any way I can support fellow OTs that want to do this type of work or have an interest in mental health or just the profession, I'm here to help. So anyone can reach out anytime.
Yeah.
We can't do it by ourselves, you know?
Right. All right. Y'all
Yeah.
heard it. Everyone
Yeah.
hit her up. So
Yeah. Yeah.
watch out what
So
you wish for.
I know. And maybe we can do this again sometime on something else. So.
For sure. For sure.